Welcome everyone to Hawthorn University's webinar series. My name is Paula Bartholomew. I'm the Director of Student Services at Hawthorn, and I'll be the moderator for this webinar. And I want to welcome you all and thank you for joining us. Our presenter is Dr. Robert Maki, and the topic is insulin resistance. This is such an important topic. There's a huge growing body of research that's indicating that chronically elevated levels of insulin that leads to insulin resistance is at the heart of several chronic diseases that afflict our society. You know, the top ones: obesity, type 2 diabetes, heart disease, high cholesterol, high blood pressure, even Alzheimer's disease. So it's important to understand that these aren't standalone conditions, but they are all related to one dysfunctional metabolic process, insulin resistance. So Dr. Maki will discuss the role of elevated insulin and what it has to do in the development of these conditions and why a whole foods-based diet is critical to improving the dysfunction. And Dr. Robert Maki is a naturopathic doctor graduating from Bastyr University. He's also a faculty member at Hawthorn and maintains a private practice. In addition to his private practice and his role at Hawthorn, Dr. Maki is the host of a healthy weight loss podcast on iTunes titled The Dr. Rob Show. It's really a fun show if anybody has an opportunity to tune into it. It's a pleasure to have you with us, Dr. Maki. Welcome, Robert. We're really happy to have you with us.
Yeah, thanks, Paula. I appreciate the introduction. And yeah, we have lots to cover tonight. Hopefully everyone will find it very informative and enjoyable.
All right, we're ready to start when you are.
Thank you. All right, so insulin resistance, I think, is we couldn't talk enough about insulin resistance, especially from a holistic nutrition standpoint, because the treatments that are out there in the conventional world, as we know, most of us do, are there, which we're going to address at least some of them anyways. Cholesterol, blood pressure, certain things like that. Those medications do not fix the underlying problem. I think a whole food-based approach is really at the core of kind of reversing this problem and stopping the progression of some of the things we're going to talk about today. So that's why it's very relevant to talk about, and all of you, as far as students go, should become experts in insulin resistance as far as I'm concerned. So a little bit about me. As Paula said, I am a graduate of Bastyr up in Seattle, which now they have a campus down in San Diego as well. I have a private practice in Southern California. I am a faculty member, and my podcast, you can check it out on iTunes, called The Dr. Rob Show. So today, as an overview, there's so many things to cover, so I tried to keep this to roughly an hour, as Paula asked, but I'll do the best that I can. Like I said, I could talk for probably 2 weeks and not stop all the information that is available for us to discuss. So we'll talk about the problem itself, we'll talk about the cause, and we're going to talk briefly about the solution. This first one is going to be more of an introductory, just try to give everyone kind of an umbrella idea of what this problem is and how to look at it when you start seeing, or if you're already seeing, your own clients in that context. I'll talk a little bit about a whole food-based diet, what that means, and some supplementation things. But for the most part, this is going to be more on the pathophysiology and where things come from and how they develop in a particular person or situation. For those of you that have not seen this or are interested, I would encourage you to check it out. It was a 6-part segment on UC TV, which is University of California TV. They're Skinny on Obesity, which goes through some of the things I'm going to talk about tonight. One of the presenters on that video series is Dr. Robert Lustig, who is a pediatric endocrinologist at UC San Francisco, which I think he is kind of a trailblazer in getting people to understand, almost like a public service announcement about sugar and its implications on the body and our overall health. The link is down below, but if you don't remember the link, it's kind of long. Just go to UC TV or even go to YouTube and type in Skinny on Obesity, and it should come up. There's 6 parts to it. Each one is about 10 minutes long. I think you'll find it fascinating if you haven't seen it yet. Okay, so let's talk about the problem. Even though we kind of inherently know what the problem is, I'll just give you some really brief statistics. The current U.S. population, this is not necessarily too accurate, but let's just assume that the population is about 305 million people. The current percentage of people that are overweight is approximately about 73%, give or take. If we do the math based on those two numbers, that's about 222, almost 223 million people that are considered to be overweight in the United States. So based on that number, that 223 million people, we can assume that 200 plus million people are also insulin resistant. Okay? So almost 2/3 of the population fits into this category that we're going to talk about today. So those of you that are becoming clinicians or plan to be clinicians and have your own practice and whatever else, 2 out of every 3 people coming into your office are going to have some level of insulin resistance. Okay? Now, in my practice, I do a lot of hormone replacement, but almost every single person that I see over the last 8 or 9 years, I would say has some level of insulin resistance. And that's why we're talking about it now. That's why I've spent so much time researching it, understanding it, and knowing how to address it, which I hope to pass on to all of you. So this is what I call the new hypothesis of chronic disease, as Paula alluded to in the introduction. Chronically elevated levels of insulin is at the heart of most pervasive chronic diseases affecting our society. So if you look down the list there's technically 9 of them: obesity or weight gain, high cholesterol, high blood pressure, fatty liver, cancer, diabetes/prediabetes, heart disease, PCOS, which is polycystic ovarian syndrome. For those of you that don't know, we're going to spend some time talking about that. And of course, dementia and Alzheimer's. Okay, so a couple of things to point out about that is 33% of the population currently has fatty liver disease. Okay, so right back to that 100 million or 200 million people that are insulin resistant, a quarter of the population has some level of fatty liver disease. That is a very scary statistic in my opinion. Polycystic ovarian syndrome, possibly 10 to 15% of the female population has polycystic ovarian syndrome, which is, again, also an insulin-resistant based condition. We're going to talk about that here in a little bit. So if you did the math on that, that's, let's say of 300 million people, half the population is female, which would be about 150 million. That is somewhere between 10 to 15 million people that are, that are women anyways that have PCOS. That is a lot of people. Now, this is just basically the same slide, but I highlighted the top portion. This is what we categorize as metabolic syndrome for the most part. Now, I think we could add a lot more conditions to metabolic syndrome, but at least from the conventional standpoint, this is what we're looking at, and I'll go through this in a little bit more detail here in a second. And that's, that's kind of not necessarily the old way, it's just we're adding on to the old way of looking at what insulin resistance really is and what it is becoming. So this is my own little diagram based on this same idea. So high blood pressure, lipids, weight gain, PCOS, fatty liver, and you can see the arrows I have going back and forth because all of those can exist at any given time. Now, fatty liver over there on the right-hand side, probably not going to happen by itself without at least a couple of the other 4 being in place, particularly the weight gain, the lipids, particularly the lipids and the weight gain for sure, but it's possible. And what I mean by the last 2, at least the fatty liver and the PCOS, usually you can tell, of course, when someone's overweight what they look like if they're insulin resistant. It's pretty obvious to see. But then it's also pretty obvious, or it's not so obvious when someone has PCOS or fatty liver. You can't necessarily see that problem. Same thing with hypertension. You can't necessarily see that problem. So now people might be falling through the cracks and not necessarily getting the treatment or the help that they need. Now, if we continue down the diagram there, you see the arrows going to more chronic conditions like diabetes, heart disease, cancer, Alzheimer's. We used to think that obesity was the one driving all of those conditions, and now we realize that at least from a literature research standpoint, that obesity is happening at the same time as all these other things. So that's why I have weight gain, high blood pressure, high lipids, PCOS, fatty liver, as kind of like the first order of problems, and usually it starts out, what I've noticed in my practice, it starts out as high blood pressure first and or weight gain, then a transition to high cholesterol, and then it progresses from there. And then fatty liver might be the third or fourth path down that that road to chronic disease. And then eventually, over a period of 10, 20, 30, 40 years, that's when someone will develop diabetes. The average age of onset of diabetes is 65. Someone in their later years might develop a heart attack, and then of course cancer, and then Alzheimer's, which is now being termed as type 3 diabetes. Right? So these are, probably chew up more doctor's visits in this country. I don't have any numbers on that, probably than all other conditions combined. So this is a really, really big deal for all of us to pay attention to. Now we're talking about insulin resistance. I think most of us students anyways, or most of you students, understand what that means, at least to a certain extent. You can kind of rationalize that. You can kind of talk that out. I think this is a very easy picture to understand of what's going on, and we don't really need to talk too much more about it, at least at this point. So you can see the normal cell up at the top. The blue, which is the insulin receptors, are 1, 2, 3, 4. There's 5 of them. That is there to designate or indicate a normal cell. The ratio between insulin and glucose is fine. The insulin allows the glucose into the cell. Everything's working just fine. Now, for whatever reason, because of the American lifestyle, as that situation changes and that cell becomes resistant, you can see in the picture below that the insulin receptors have been down-regulated. That is the term we use in physiology that makes the cell, and when we're talking about cells, we're talking about specifically your liver cells, your fat cells, your muscle cells, even your brain cells for that matter. They become resistant to the insulin, and that resistance part is the down-regulation of the receptors. Now you have more insulin there, less receptors available to respond to that insulin, and now over time the blood sugar goes up. You can see there's more glucose molecules there than there was in the normal cell picture. Right? And this is just a normal consequence, so to speak, of the body trying to not be overstimulated over time. The downregulation of those receptors happens on a lot of different areas in the body. It just so happens that this is one of the most common manifestations of that. Now, this is another great picture I found as well. There's a lot going on here, so you might not be able to see it exactly. I'm not going to spend too much time going through this, but you can see all the different areas of where insulin resistance or that has an impact on the body. The pancreas, the liver, the fat cells, the blood vessels, macrophages, the arteries. Everything is being affected by having overabundant amount of insulin over a period of time. What I mean by time, not just weeks or months, but years, if not decades, if not multiple decades, is when these problems begin to occur. Now, from a conventional standpoint, you go to a doctor. Someone goes to a doctor, once or twice a year. They get their blood drawn. They do, some very standard blood tests. A lot of times, as I said, 2/3 of the population is overweight. You can usually look at someone and tell whether or not, or at least make a pretty good bet whether or not they're insulin resistant or in some stage of that. Okay, now when you do a blood test, you're also looking at some other things. You can also look at someone's blood pressure. If it's greater than 140 over 85 millimeters of mercury, you have an elevated total cholesterol, an elevated LDL cholesterol, which as we know is our bad cholesterol, elevated triglycerides, which is the one that I usually pay attention to the most, greater than 150, a low HDL, which is our good cholesterol, lower than 40 for men, lower than 50 for women. Men have a hard time getting their HDLs above 40. Women usually are always above 50. So when you see a woman that has a HDL lower than 50, that is a little bit of a red flag sometimes that they may be, again, insulin resistant, especially if the other ones are elevated. A fasting blood glucose, this is a pretty common issue. This is where a doctor will tell their patient that, oh, you're kind of borderline, you're quote-unquote pre-diabetic, but they don't really do anything about it. They may say, oh, you should make some dietary change, but they don't really necessarily give them the tools or the information that they need that all of you can fill in for them. Okay? Because again, that same process, if we look over a period of time, someone's blood glucose level has probably been increasing steadily for the last 5, 10, 15, 20 years. And there's been a gradual progression to those numbers, but that still is not necessarily seen as a big deal. Okay, so when it's hovering right around that 100, 105, 110 mark, that's when something should absolutely be done to make sure that it doesn't progress even further. I always do, with my new patients, I always do an insulin level, but this is a test that is routinely not done in the conventional world. It is done quite frequently in the functional medicine, the naturopathic, the functional nutrition world, and rightly so. I think every person on a screening should have their insulin levels checked on a regular basis. I would be an acceptable number. The range goes from, I don't have it listed on here, but you can write it down. The range on any given lab is between 2 to 27 or 2 to 25, which I think is way too high of a range. Ideally, someone should be less than 10, and even more ideally should be less than 5 on a fasting insulin. Okay, now we'll talk about that later, but a fasting insulin only gives you part of the story. What is really more indicative of insulin resistance is someone's response to a meal. Okay, so what they call the postprandial glucose and insulin level 2 to 3 to 4 hours after they've eaten. But that can be really challenging for people to go to a lab like that. They've been there for 4 hours or something. We'll talk more about that in another webinar. Also, a BMI greater than 30. A BMI, as everyone knows, is body mass index, has some flaws. It's not a very good, a very accurate descriptor or, I guess, indicator of obesity, except when you get to those higher numbers. Okay? So again, if someone's above 30, it's pretty much a guarantee that they have too much weight, and now that becomes a risk factor for metabolic syndrome and increased risk of cardiovascular disease. The other one, which I think is probably a little bit of a better one, is waist circumference, greater than 35 for women, greater than 40 for men. Again, trying to illustrate that central obesity around that spare tire around the middle. Men always put their weight in the middle. Women that put their weight there, they have that apple shape as opposed to the pear shape, for the most part. Those are definitely risk factors as well. So a lot of those can be done, at least a couple of them can be done just on visual, either the blood pressure or the waist circumference or the BMI. The other ones, a blood test would need to be done. Now, when we're talking about obesity, again, that makes a lot of sense as far as insulin resistance being the underlying cause there. However, there's a lot of people, especially what I've seen in my practice. I do work with a lot of people in a weight loss capacity, but I see the signs of insulin resistance in the slender population. Not necessarily probably as much, but still a large majority of people that you would not think that would have any type of metabolic dysfunction, they routinely do. Okay, so just follow along. Sorry for the cartoon kind of picture there. I didn't mean anything by it. It's the only picture I could find that showed a skinnier person and an overweight person. So just bear with me. Okay, so for healthy metabolism up there on the left-hand side and then metabolic disease on the right-hand side, for a skinny person or a normal weight person, 60% of them are going to have healthy metabolism. And now of that same type of demographic, 40% of normal weight people are going to have metabolic disease. Okay, so that's that 40%, that's the segment of the population that I'm talking about that visually you can't tell there's anything wrong with them. But you do a blood test or you look for some of the other things that I am going to talk about today, now you get an idea that they certainly do have some metabolic dysfunction. Now for the overweight individual, 20% of them will have healthy metabolism. Okay, so again, they have maybe 50, 60, 70, maybe 100 pounds overweight, who knows, and you do a blood test or you do something like that and they have no signs of high blood pressure, high lipids, any of those things are present. Their metabolism is relatively fine and they'll live to a ripe old age and not develop any of the chronic conditions that I've already laid out. Unfortunately, 80% of the overweight population does have or will have metabolic disease at some point, leading to those chronic conditions, the type 2 diabetes, the heart disease, the dementia, and certain cancers. Okay, so again, that is that if 70-some% of the population is overweight, 80% of that 70%, again, there's a lot of numbers there, are going to be in need of some help. That medication alone does not necessarily solve. And nutrition is the cornerstone. And the last time that I went to the doctor, they didn't really talk too much about the dietary approach from that. So that's where there is a huge underserved population that needs the proper information on how to address these problems. Okay, so that's just a, you can see them both there. It's just a third slide with them all combined. The healthy metabolism is 60% and 20%, and then 80% and 40%. Hopefully that made sense to everybody. Now this is a really detailed slide. I didn't mean to overwhelm anyone, but you can see there inside the circle are the the cardiometabolic risk matrix, the different problems, and then on the outside are kind of what results as a results from that. So you can see up in the upper left-hand corner you have the predisposition, and then that is either in conjunction with obesity or separate from obesity, leading to insulin resistance. That goes back to what I just talked about a second ago in the previous slide. And then that goes into this matrix, and a whole bunch of problems result from that, including the abnormalities to cholesterol, which we're going to talk about, or I'm going to talk about on the next webinar, which is later this summer, kind of the part 2 of this current webinar. And then hypertension, you can see down there at the bottom, acute phase reactants, things like CRP, which is another blood test, fibrinogen, which is what makes your blood clot or your platelets stick together, and then PAI1, which is also another thrombotic type of a reactant for the most part. That both of those, the fibrinogen and the PAI1, increase when someone is insulin resistant. So that's why when someone is insulin resistant, their risk of having a heart attack goes up significantly, right? Because they, their blood is thicker, or it sticks together, or the proper term is it increases their platelet aggregation, meaning that the platelets are sticking together easier than they normally would. That's why a cardiologist will recommend someone take an aspirin, a baby aspirin a day to decrease platelet aggregation. Okay, now, in my experience, fish oil works very well to do that. Vitamin C works very well to do that, along with garlic as well, to decrease platelet aggregation. Almost as good as, if not better than, warfarin, Coumadin, those kinds of things, at least in my experience anyways. One of the things that they tell people not to do when they take Coumadin or warfarin is they tell them not to eat vegetables. Well, maybe if they ate more vegetables, then maybe they wouldn't need the Coumadin or the warfarin in the first place. But I'm not really sure why it's done that way. Okay, so this is just another diagram, and the reason why I put this one here was to highlight at least the effect that insulin resistance has on blood pressure. I tried to find a couple of good pictures, and I really couldn't find one. This is at least the simplest one that I could find. You can see over there under number 6 and 7 as the hyperinsulinemia goes up, that basically creates an activation of what's called the renin-angiotensin-aldosterone system. This is how our body regulates blood pressure, and one of the effects of aldosterone is to basically retain sodium from the kidneys. So if you have more aldosterone, you're going to retain more sodium. That means your blood volume is going to go up, meaning that your blood pressure is going to go up. Right? And that's the real reason for this slide. You can see the other things that are happening, diabetes, the dyslipidemia, and the leading to atherosclerosis there in the bottom. But that pointing out that simple mechanism, but a very profound mechanism, because one of the first things that a person will develop in this progression, as I said, of insulin resistance is high blood pressure. They may be in their early to mid-30s, maybe their early 40s. They come in to see you as a client, and sure enough, one of their first medications is a blood pressure medication. Okay, so right there, the fact that they've been to a doctor, they've been evaluated a couple of times, and they're already on a medication for that says, okay, there's an insulin problem going on here. And then some time will go by, and that will progress to the high cholesterol, the fatty liver, the weight gain, all those other things. So there's definitely a chronology to these medications, or to the metabolic process, if you want to call it that, but an easy way to identify is by the medications people are taking, because that's just the way the system is. Okay, so we'll move on. Now, in addition to the signs, which are basically anything that can be recorded. A symptom is something that cannot be recorded, maybe that is more on a subjective plane. Okay, so in addition to the BMI, the hypertension, the dyslipidemia, there are a few other things that go along with insulin resistance. So I already mentioned PCOS, fatty liver. On a blood test, you'll see in poly-cystic ovarian syndrome, elevated DHEA and testosterone levels. For anyone that has that or knows anyone that does have that, those two tests are routinely done, and you'll see those numbers quite high in those female individuals. Fatty liver disease, we'll talk a little bit about that and where it's coming from or why. You'll see slight elevations to AST and ALT on what they call a comprehensive metabolic panel, which is abbreviated as a CMP. Very simple test, but you'll see just slightly elevated numbers. And most of the time when I see that, I either ask, have you been evaluated for fatty liver, or I may send them for an ultrasound, and sure enough, they have the signs of that. I would throw gout into this discussion. If someone has a history of gout, multiple reoccurring episodes of gout, then they are in some level of insulin resistance, as well as some physical things like skin tags, hirsutism, which is women having male characteristic hair growth, both on the face, around the nipples, and the abdominal below the umbilicus, on the abdomen below the umbilicus. And then the other one is acanthos nigricans, which I'll show you pictures of all three of those last ones, because again, most of you cannot necessarily do a physical exam on your clients when you're working with them. However, it's very easy just to observe and look at their skin, or maybe ask them some questions regarding those last three things. If they have them, then you pretty much know what's happening with them metabolically, whether or not you've seen a blood test, whether or not you have worked with them in any other fashion before. Okay, so this is a very simple one. These are skin tags. These are mobile little fleshy little tags. I guess you can kind of flick them with your finger for the most part. It looks like a little punching bag almost, and they can be anywhere from the neck to the back to the arms to the torso. They can be in quite a lot of places. Now, as insulin resistance improves, or their insulin sensitivity improves, these skin tags will resolve, or at least some of them will resolve. Chromium is a good way to do that, which is a mineral, again, for proper insulin balance. That is I've heard some cases where people actually have been taking chromium, or have been told to take chromium either by their doctor or on their own accord, and their skin tags actually resolve. So that's something to pay attention to. This is a kind of an extreme example, but you can tell that's a woman's face, and she has, I would say a little bit more than a 5 o'clock shadow. But this is an example of hirsutism, where women that would routinely have to shave on a regular basis, whether it's the jawline or the mustache, they're growing much more hair than they had ever cared to. Certainly not very pleasant for a woman. This is another example. You can see the dark, kind of coarse hair, almost in the same pattern as a teenage boy would develop. Maybe not so full, but still very, very characteristic nonetheless. This is the acanthos nigricans, which are, a lot of people might refer to these as liver spots for the most part. These are, you can read it there, the description. This is a descriptive term for a velvety or verrucous brown to black area of hyperkeratosis. So the insulin basically drives the hyperkeratosis process in the skin, causing this hyperplasia. They can develop certain plaques, which a couple of the other pictures are better indications of that. I don't have a picture of it, but you can also look at someone's feet. I'll show you a picture of the hands, but you'll see this on the feet as well. And on the lower legs, from the knee down, usually from the mid-lower leg down, people will have hyperpigmentation of their lower limb. And that can also be an indication of hyperinsulinemia as well. This is on the back of the neck. You can see that color there, and it's kind of got a plaque formation to it. This is the color of what the lower legs will look like. You'll see this also in Cushing's disease. You'll see this hyperpigmentation, which for those of you that don't know, Cushing's disease is a hypercortical state where someone is producing too much cortisol. Could be from a variety of different reasons. This is on the hands, just a few different plaques on the back, a plaque on the back of the hands. I've seen these types of things numerous times. Most of the time people struggle to get an accurate diagnosis, but you can look up some pictures on the internet just to get familiar with what this looks like, so when you do see it, you have at least to have an idea of what it might be. This is on the elbow. How many people do you know that have patches or rough patches, areas like this on their elbows? This is a pretty common place. It feels very coarse, very rough. They're usually trying to put a lot of lotion on it or something like that. That is another example. This is on the, of course, on the palm, and the cracking that you see around the thumb and around the top part where the fingers attached to the hand. You'll see that same type of cracking on the feet, on the soles of the feet, and it can be another indication or another manifestation of it. It looks just like that, and a lot of times when I do an evaluation of someone, I'm looking specifically for this, but more so on the feet. You see it a lot in diabetics. Diabetics have usually very unhealthy looking feet, and if you can imagine if this was someone's foot, this is what it would look like. Very dark, deep, thick, almost cracks in the skin for the most part. So pay attention for that. It's really easy to have someone just turn their hands over and look at their palms. I live in the Southwest where it's hot all the time, so everyone's always wearing either flip-flops or sandals, so it's very easy to observe someone's foot very easily, very simply, without disturbing or intruding, and also not doing anything that would be outside of a scope of practice as well either. Okay, so now we're going to move on. So those are some things to visually look at, to pay attention to as you're evaluating someone, as you're putting together their nutritional plan. I think that is very detailed as far as that goes. Now we're going to get into talking about PCOS a little bit and where that comes from. Again, 10 to 15% of the female population has PCOS, so this is a very large percentage of women. The number one reason for infertility, and that is becoming a bigger and bigger problem. More and more women want to become pregnant but are having trouble becoming pregnant, and there's a lot of reasons for that. It could be from xenotoxins in the environment, but it also can be from hyperinsulinemia, which then increases their androgen levels. Okay, that's why I said a few minutes ago, a blood test that is typically done is a DHEA level, which is the predominant androgen in women, and a total testosterone level. Now you can see here in this diagram there is right in the middle of insulin resistance, it goes to hyperinsulinemia, which then goes right to the liver, and that has an impact on which they abbreviate as SHBG, sexual hormone binding globulin. Because of the hyperinsulinemia, that decreases sexual hormone binding globulin, which then makes more androgens available or bioavailable to the target tissues, in this case the ovary, and now the ovary becomes basically it undergoes a hyperplastic state, and now it has multiple cysts and whatever else. So a very good question to ask if someone, and people don't necessarily understand this diagnosis of PCOS. Now a lot of doctors are educated, of course, they know what they're doing for the most part, and they do eventually figure this out. But if you've ever consult with a female and she mentions she's had female troubles or this or that, always ask if she's ever had a history of ovarian cysts. Okay, whether or not she has the diagnosis or not, just because of that little bit of inquiry, have you ever had a cyst before? Oh yes, I have them all the time, or I've never had one. It just gives you that little bit of information to know metabolically what's happening with them. I see it a lot with female hormonal issues. They go to the gynecologist does some things, when in reality it's not a female hormone problem in the first place. It's an insulin problem in the first place. And if it's never really dealt with that way, again, what do they typically do for things like that? They just put them on birth control, and that really does not fix that underlying problem of insulin resistance. And now if they have full-blown PCOS, where it's showing up on a blood test, the DHEA and the testosterone, then the typical approach at that point is to prescribe spironolactone, which brings down your testosterone levels, and another one called metformin, which is a diabetes medication, and that's about it. There's never any talk about diet. There's never any talk about nutrition or how that should be approached. Again, a very good opportunity for all of you to fill that void. So a lot of going on in that picture. I just want you to kind of get a look and be able to visualize that as opposed to me talking through everything. There may be some things that you're not really quite sure about, but I think the picture says quite a bit. It's pretty simplified for the most part. This is another example of the same thing, just with a little bit more, instead of text, a little bit more pictures. It kind of shows you what's happening here. So the LH up there at the top at number 1, that is luteinizing hormone. And if you follow the arrows down, that's what stimulates the ovaries to produce testosterone, which of course doesn't really need to happen too much. That's the androgen. A little bit of testosterone in women goes a very long way before you start causing problems. But then over there on the right-hand side, you can see the pancreas, the insulin resistance, and the hyperinsulinemia, and how direct of a route that has right to the pituitary, and the direct impact on increasing LH. Okay, insulin drives LH levels, which then drives androgen levels. Does the same thing in men, at least in the short term, anyways. Not necessarily such a good idea in the female population. So again, another very good picture. I think there's a lot going on here. We don't really have time to go into the entire thing, but it gives you a visual of what's happening, and also more of an understanding of how it should be approached when someone comes in to see you that has a history of either ovarian cyst or if they've actually been given the actual diagnosis of PCOS. Okay, so you can see I like a lot of pictures. They're just, I think each one you get a little bit of information out of each picture. This is pretty much the same thing as the last one, but I think it has some nice little details there. You can see the reference down below if you're interested, but if you want the slides, my email's at the end. I'll send the slides to you. I'm not sure if they're posted anywhere else or not. Again, these pictures are just kind of fun to look at and get a sense of what's going on there. Okay, so now let's talk a little bit about the cause. Again, we just talked about the problems. We talked about insulin resistance in general, the 9 things that result as of insulin resistance. In some ways, insulin resistance could be the cause, but now we're going to talk about what the real cause of all those, what's leading to the insulin resistance and all those 9 things. So how do we get here? So we have the environment and our expression of our genes in relationship to the environment, which, as we know, is called epigenetics. We used to think that our genes, what we had was what we're born with, which is true, but we didn't really understand how much our environment played a role in how our genes are expressed, meaning that they were given a certain level of we're born with certain genes from mom and dad, but those genes are allowed to be changed based on the environment. So, and I think we can all understand what that means from a stress standpoint, from a dietary standpoint. Whether it's sugar, refined carbs, gluten, genetically modified food, I mean, these are all real and present dangers. Pesticides, herbicides, different toxins, too much light, not enough sleep, even the bacteria. The question is now, and I know all of us understand about bacteria and gut flora and how important that is, the question now in the research realm is, do we serve them or do they serve us? And I think that the reality is, as the research comes out, is that we kind of serve them in a respect just because of how big that biomass is. 100 trillion organisms in your colon, for the most part, is a huge number to comprehend. When you think about the human body, there's average maybe somewhere between 7 to 10 trillion cells in the entire human body. We have 10 times that amount inside of our colon of bacteria that are supposed to be there for the most part. So those have to have an impact on this whole picture, which we'll talk maybe more about in the future. Okay, so the 21st century then, we'll kind of whittle that list down. You can see there's quite a few things there. We could spend a lot of time on each one of those, but we don't really have time to do all that right now. So we're going to pick on what I think is the one that is the most prevalent, especially when you're talking about insulin resistance, which is, of course, sugar. Okay, now there's a lot of talk now about this type of sugar and that type and what sweeteners are good. And sugar is basically sugar. Okay, there's no way to slice that, whether it's honey or agave or this or that. If it has sugar in it or some derivative of that, it basically is kind of fits into this category of what we're talking about. Now, we could make an argument for some of those things, so don't quote me on that as being, there's exceptions to every rule for the most part, but sugar is sugar. In a susceptible individual, which is what we're talking about here, someone that is insulin resistant, someone that has fatty liver disease, someone that has PCOS, someone that has type 2 diabetes, this is where the details really matter the most. Okay? We're not going to spend too much time talking about artificial sweeteners, but I will mention xylitol as being one that would be somewhat acceptable, but even still, even at that level, the idea is to get people away from consuming all the quote-unquote sugar that they're consuming. Also, the chronic stress and the lack of sleep, those two kind of go hand in hand for the most part. We don't really have time to talk about either of those, but at least I mentioned them as those being the triad of things that are driving all this metabolic disease in our country and around the world for that matter. So according to the data, this is data published, almost 14 years ago now, estimated annual amount of sugar consumed per person per year, which I have it as a question mark there, was actually 160 pounds of sugar per year. So if that was 14 years ago, give or take, that number is probably even higher now. That's what's killing us all. That's what's driving, obesity, diabetes, heart disease, all those things that we've been talking about. Not because we're consuming too much fat, not because we're consuming too much red meat, anything like that. It's because there's just unlimited access to sugar on an everyday basis. I would include some of the refined grains into that. Anything that comes in a bag or a box, even if it says it's gluten-free and it comes from Whole Foods, it's still a refined grain for the most part. Okay, now, again, there's exceptions to all those things, and I don't want to make that a hard and fast rule, so I don't want to get a bunch of emails and say, what about this and what about that? There's exceptions to all of it, and I think there's a lot of debate about what constitutes a healthy food, what constitutes a good food from a grain standpoint. Again, we could probably all agree if it's a whole food, it should only have one ingredient. It shouldn't have a label. It shouldn't have too many ingredients. If everyone followed that type of an idea whenever they sat down for a meal, they probably wouldn't have any problems. But we all know that people don't tend to do that very often. They want to know what they can eat that is out there in the marketplace, and that's where the problems come from. Okay, so when we break down the sugar molecule, this is, from organic chemistry class, this is a molecule of sugar. On the left is a molecule of glucose, on the right is a molecule of fructose. Okay, now you don't see them, but the ring, the 6-carbon ring, that's what the little lines there from line to line, that is indicating a carbon atom. Okay, and then on the other side you have the 5-carbon ring of the fructose. Again, the carbons are kind of assumed that you know that based on this structure. And this is just a little bit blurry, so I apologize for that. Don't worry, there's nothing wrong with your eyes. It's just the resolution of the image. You can see the carbons are the purple ones, the oxygen are the red, and the hydrogens are the white as far as the sugar molecule goes. So sugar is sugar. And the glucose, fine, it's not really that necessarily big of a deal for the most part, but it's the fructose, which we're going to talk about, that is driving most of this insulin resistance, fatty liver, high cholesterol, type 2 diabetes, weight gain for sure. And that's what we need to, I'm sure all of us understand that, especially when we're talking about high fructose corn syrup and its level of toxicity that it exerts. But our clients and our maybe even some of our family members don't probably understand that very much at all. Okay, so high fructose corn syrup, introduced around 1980, which is when, ironically enough, the rate of obesity began to skyrocket. It is now considered to be a bona fide hepatotoxin. So hepatotoxin meaning that it's toxic to the liver. In comparison to ethyl alcohol. Anytime someone consumes beer, wine, or distilled spirits for the most part, fructose has the almost identical impact on the liver and body as alcohol does. That's a pretty scary thought to think about. Okay, so every time someone has a soda pop, okay, they are basically doing the same thing to their liver if they were drinking alcohol. Okay, so think about all the children out there that are drinking things that have high fructose corn syrup on a regular basis. They might as well be drinking a Bud Light, right? Which of course sounds ridiculous to think about, but that's what they're doing every time they're consuming foods like that. I'll show you another slide here in a second. The high fructose corn syrup is driving that fatty liver, what they call non-alcoholic fatty liver disease, or NAFLD. If you just type in NAFLD, you'll come up with some resources. That is becoming a very unknown epidemic in this country, and the problem is there's no drugs that address it. That's why it's being ignored. Okay? You don't really know you have it until, ironically, your liver enzymes go up and you go in for a, sometimes a incidental ultrasound, and oh, by the way, you have fatty liver disease. But even at that point, there's no necessarily a significant or common treatment for it. They usually just wait and see what happens, and then eventually they develop like liver cancer and scar tissue and cirrhosis and things like that. So it's really unfortunate. The other big problem with high fructose corn syrup is it basically causes accelerated fat storage, meaning that as the fructose goes in, it just turns into fat immediately. It doesn't go anywhere else. Your body just turns it into fat. And that is, again, what leads to the obesity problem, but then also fatty liver and everything else. This is a really detailed diagram. I'm not going to really go through this much at all, but this is a metabolism of fructose. There's a couple of things when you look at this that kind of jump off the page. You see the fructose over there on the left-hand side, upper left-hand corner. You see the inflammation right there in the middle of the circle. And that leads to some of that hepatic IR, which is hepatic insulin resistance. And then that down at the bottom right-hand corner, you see TG. Okay, that is basically triglyceride formation. So the point of this diagram is to show that as the fructose comes into the cell, mainly the mitochondria of your liver cells, that's where all this is taking place, inside of the mitochondria in the liver cell, it is producing liver fat in the form of triglycerides. And then the liver gets overburdened, the liver doesn't know what to do with it, it starts storing it away inside of its own cells, and it just keeps progressing over and over and over. When we do the next webinar, we'll talk a little bit more about this. You can see it's a very, very complicated process, but this process is very similar, at least the net result, what happens based on consumption. Chronic exposure to fructose is basically the same thing as chronic exposure to ethyl alcohol. Okay? So again, next time you see a child drinking a soda pop, you might as well replace it with that Bud Light because they're really doing the same thing. That's a really funny visual for the most part, but it's kind of sad at the same time. So glucose versus fructose. Glucose, as I said, from a body response standpoint, isn't really that big of a deal. Pretty much all your cells in your body use glucose. Your brain, your muscles, your adipose tissue, your organs, and your liver will use about 20%. Okay, your liver, on the fructose side, your liver, 100% of it is metabolized through the liver. Okay, and that's where, again, it goes directly to the mitochondria, and as a result, it is turned into triglycerides, and the liver just can't keep up. If there's too much coming in on an everyday basis, and think about how many people are having soda pop or some type of beverage like that, or some type of processed food, candy or cookies or who knows what, on an everyday basis, and they're putting a huge burden on their liver. The liver can't keep up, and now that's when the disease begins to happen over time. That's when you start having high cholesterol levels and other things as a result of that, because your liver is just incapable to keep up with the demand. Okay, so this is what I described a few seconds ago, or a few minutes ago, talking about ethyl alcohol and fructose. Chronic exposures to either one over time, the diseases that manifest are almost identical to each other. Okay, hypertension, cardiomyopathy, dyslipidemia, pancreatitis, obesity, malnutrition, hepatic dysfunction. ASH is alcoholic. I can't remember right now. ASH and NASH. One is alcoholic and one is non-alcoholic for the most part. And then fetal alcohol syndrome and addiction. And then pretty much the exact same list on the other side. Fetal insulin resistance. I mean, that's something that most people never even heard of before, but certainly is a ever-growing problem, which is why every generation becomes bigger and bigger because of the fetal insulin resistance. And then the idea that does fructose lead to addiction or at least habituation? There's some controversy about that. I think that it certainly does lead to a certain level of addiction. People cannot seem to stop eating these types of foods, not because they don't have willpower, not because they're weak-willed or anything like that. It's because the mechanisms inside the body and the pathophysiology makes them want to eat more of it based on hormonal change, enzymatic change, neurotransmitter change. People are pretty much at the mercy of those types of foods. Okay, so let's talk a little bit about micronutrients. Now, the standard American diet is pretty much 50 to 65% of the daily calories come from carbohydrates. Okay, 25 to 35% come from fat, and then 10 to 15% come from protein. Okay, that's what the government's been telling us to do for a long time. This is the ideal macronutrient intake. But if this was the ideal, then why is everyone getting bigger and sicker as time goes on? Partially because of that carbohydrate, 50 to 65%. It's all the wrong carbohydrates. That's pretty obvious. I think we can all agree with that. Okay, now, if we look at the insulin response of those types of foods, we look at carbohydrates. Depending on the carbohydrate, they can have a low, moderate, or high impact on insulin. If it is let's say broccoli for that matter, it's going to have a very low insulin response. If it is a can of Coke, it's going to have a very high insulin response. Proteins are going to have relatively a low to moderate, depending on the size of the protein, insulin response. And fat virtually has no impact on insulin at all. Right? That is a little bit unusual. People don't necessarily understand that last part, that fat does not respond to fat intake. Now, here's where it gets complicated. For those of you that are my students, you've probably heard me say this before, but this is critical to understand about the standard American diet. Now, if we combine the macronutrients, carbohydrates and protein, again, you get a low, moderate, or high impact on insulin, depending on the type of carbohydrate. If it is asparagus and a steak, the insulin response is going to be relatively low to moderate, depending on the size of the steak. If it is a steak and a Coke, again, then that insulin response is going to be very high. But not because of the protein, which we'll get to in a second, because of something else. If you combine fat and protein, the insulin response is low to moderate, again, depending on the size of the protein. And then here's where it gets interesting. If you combine carbohydrates, and I put parentheses there, sugar, and you combine that with fat, and that's what the standard American diet really is. It's a combination of fat and sugar together. That's where you get the super high skyrocketing levels of insulin. And if it is bona fide sugar that you're consuming, that's where the fructose burden comes in as well. So now it's kind of coming in two ways, which is having a direct impact on the liver because of the fructose consumption, but then the high glycemic impact as well is making your insulin levels surge even higher. Okay, that last part is really what is driving all of it, because in Mother Nature, there is not a single food in Mother Nature that has fat and carbohydrates in the same food at the same proportion. Okay, now, I ask that question of my students and even some of my patients, whatever else, and they always come back, okay, what food has fat and carbohydrates in the same food? And everyone always says, and some of you are probably chiming in or thinking about it right now, you can think of avocado, which has a lot of fat, very little carbohydrate. You can think of olives, maybe coconut, but the list is very, very short, and it's usually one or the other. It's usually higher in fat and lower in carbohydrate, or higher in carbohydrate and very low in fat. It never has an equal proportion or even a moderately equal proportion to both of those. But if you think about the standard American diet, and even the healthy food, the quote-unquote things that are supposed to be healthy, sold at certain grocery stores, even those things are a combination of carbohydrates, meaning sugar, and fat. And that's the part that the American public is really kind of ignorant against. They don't understand that that is really leading to their demise in some way, shape, or form. Okay? That becomes a very big role. The combination of sugar and fat becomes a very big role for menopausal women as well, because if you ever worked with a menopausal woman before, which a lot of you will, once you get into practice, their big thing is losing weight, of course, but they have a very, very hard time doing that, partially because their tolerance of foods that contain fat and carbohydrates together isn't very good anymore. So now if they're still consuming foods that way, it's going to make their weight either keep going up or it's not going to go down based on that. So something very important to understand. It's pretty obvious when someone points it out, but again, most of our clients have no clue. They're still on the low fat kick. They're still trying to avoid fat, which in some respects is okay, but usually that means more sugar they're consuming or more carbohydrates they're consuming as a way to compensate for that. Okay? That can be a very big problem if that goes on too long. Okay, so now I'm not sure how much time we have left here. I'm just kind of rattling along, so I want to make sure we have some time for some questions. So we're just going to run through this really fast. So the clinical goal here.
It's an important part, Robert, so it's good to get to the solution. You're fine.
Right. Okay, thank you. All right, so the clinical goals, at least the clinical goals that I established for myself and my clients, and I would encourage you to do the same thing. Simplify them. Don't make it too complicated, but then have very defined goals of what you're trying to do clinically, at least in your own mind. These don't necessarily need to be communicated to your clients, but they should be what you're delivering to them as far as recommendations should elicit or should illustrate these kind of behind-the-scenes goals anyways. So just simply balancing hormones, reducing inflammation, and improving liver function. And now we talked a lot about the liver already. We talked a little bit about inflammation, and certainly I've talked about the big hormone, which is insulin. Just to move forward, cortisol I think also plays a very big role in that with stress and the very busy 21st century. In some ways, the insulin and the cortisol kind of go hand in hand. If you have insulin dysregulation, you have cortisol dysregulation, and vice versa. Okay? In reducing inflammation, eliminating sugar consumption, as I said, getting rid of the high fructose corn syrup and just sugar in general, that is going to reduce inflammation on its own. And then, of course, allergens. So the wheat, the corn, the dairy, the soy, the nuts, the citrus, and unfortunately, I would throw eggs into that category. I'm a big, I eat eggs a lot myself. I encourage my clients to eat eggs, but unfortunately, they're probably one of those majorly sensitive foods for some individuals. And that you can decide for yourself if it's appropriate or not. And the last one is improving liver function. Really what that means is minimizing or eliminating the burdens that are coming into the body from external sources, the sugar, the caffeine, the alcohol, the meds, the stress, and then improving phase 1, phase 2 detoxification. If you don't know what those things are, we can talk about them on a later webinar. But making sure that the enzymes that are in the liver are working well and able to get the toxins in and out. Meaning what I mean by that is in and out through either the feces or the urine. That's how your liver brings them in as a toxin, turns them into more of a toxic substance, and then makes it water soluble so your body can excrete it out through those channels. Okay, so enhancing that process as much as possible. And also with the inflammation and improving liver function, I would say maintaining or establishing good gut flora would fit into both of those categories as well. Because the imbalanced gut flora can drive inflammation, and the imbalanced gut flora can increase the burden on the liver as well. So that needs to be kind of figured into your nutritional plans. Okay, so from a food standpoint, to be honest, we don't need to overthink this. This is really simple stuff for the most part, at least for the Hawthorn community. We know what we want our people to eat. The problem is getting them to eat it. That is always the challenge. Okay, so low glycemic foods, low glycemic index foods, low glycemic load foods. That's where you start. Okay, and you can see where the green and yellow should be a majority. I would say 80 to 90% of their food should be from the green, either low glycemic index or low glycemic load foods, which are going to be basically proteins, vegetables, maybe some legumes, a little bit of fruit, not a lot of fruit. In a susceptible individual, that can be a problem. If someone's normal weight doesn't have any sign of metabolic dysfunction, then they can have all the fruit they want. Okay, but if they do have metabolic dysfunction, a little bit of fruit, but not every day. Not a big smoothie with a banana and berries and all these other things in there, because now the glycemic load of that is going to be too high. Okay, and you're going to be putting more stress and strain on that overall system that you're actually trying to fix. And then, of course, you can see the high glycemic index foods and the high glycemic load foods. Those should be done on a very rare basis, if at all. I think that it's unrealistic to think people are never going to have them, but once in a while is, I think would be fine. Once there's a certain level of progress and some things have been, whatever goals you've established for you and your client those milestones have been met. Okay, so it doesn't need to be any more complicated than that, but there is different variations. Now, again, from a PCOS standpoint, those are, they come in, they want to lose weight, they're 180 to 220 pounds typically, maybe not always, but that's usually where they range, maybe 175, somewhere in there, and their goal is to lose weight. They are the most challenging group of people to get to lose weight there are out there. And sometimes just setting them up on a healthy diet, quote-unquote healthy diet, isn't always a weight loss diet, okay, or a fat loss diet. Those two things are, a healthy diet and a fat loss diet are not necessarily the same thing. Okay, so we don't really have time to go into that too much right now, but usually, though, for the most part, if someone is coming from a very highly processed food diet, just getting them to eat real food without too much selection, okay, just getting them to eat real food for a change is enough to get this ball rolling. And that usually, in and of itself, will start to have a huge impact on how they look, how they feel, all their metabolic parameters, because their body is just not used to eating, for the most part, real food. So let's not overcomplicate it. Let's keep it as simple as possible, holding people accountable when they need it, but also, understanding when it's not. So this is a pattern that I've noticed over the years, not necessarily that I've noticed it. Other people probably have as well too. It's just something that I pay a lot of attention to. That people wake up in the morning, they have no food. If they do, it's either coffee or carbs. And usually carbs is a bowl of cereal, it's a donut, a bagel, all the wrong kind of carbs that they don't need. Mid-morning they get hungry, maybe not, maybe more coffee, more carbs. Lunch, they're usually pretty hungry. 2:30 in the afternoon, they get that a commercial you see on TV, the 2:30 feeling. They get a significant energy crash. They use more carbs and coffee to pick themselves back up. That's when they're going back to Starbucks. They're going back to the coffee bar at their office or outside, in the little cart outside, wherever it is. And they get home at dinner, and dinner is usually their largest meal of the day because usually by that point they're starving to death, and then the cravings kick in usually after dinner. Okay, so this leads to not only cortisol imbalance, but certainly blood sugar imbalance. As you can see here, they're on the what I call the blood sugar insulin roller coaster. You could probably put cortisol in that same thing, and it's just up and down all day long. The spots on the pattern here where they use carbohydrates is where their blood sugar is dropping low. So in some ways they're going through a kind of pseudo hypoglycemia on a multiple time per day basis. They don't even realize it. Okay? And that persists over time, and then that's when the weight gain happens, that's when the high blood pressure happens, that's when the high cholesterol, the fatty liver, the PCOS. This happens over a period of, again, months, if not years, if not decades, because our society is so prone, is so established in this pattern. Even as students, we wake up, we're going to school, we wake up at the crack of dawn, we got to be to school, we got to hurry, we got to rush, we're not hungry, we don't eat anything, and this progresses all the way through adulthood, all the way through our 30s, 40s, 50s, and 60s, and then we wake up one day at 65, maybe even earlier than that, and we have type 2 diabetes or something. Okay, so this is I think, a very significant thing to adjust and to change early as possible. We don't let children eat in school. I'm not sure quite why, but they should. They should be allowed to snack because when they do eat, they want to eat all the wrong kinds of foods, which then only drives the metabolic dysfunction over time. Okay, now those are some societal issues that we can't necessarily talk about now, but you can see how our society, from students all the way on through, it is kind of setting us up for failure in some respects because we just don't have time for our nutrition. Okay, so this is what I think it should look like, very simply, no chaos, just a nice, easy schedule. There's a lot of pushback to this. People, have a hard time, probably more than anything, have a hard time establishing this pattern. If for one, it's too many times a day, they can't eat this much, they just don't feel very good, they don't feel hungry, they feel a little bloated and nauseated. Getting them on this schedule, they have no problem eating later in the day. Dinner and after, they have no problem eating there because that's what got them there in the first place. but trying to get them to eat more food early on is a very big struggle. But I push it a lot in my clients. I want them to start up the day with a good source of protein and whatever. They can have whatever else they want with it for the most part, but they have to have breakfast. They can't have the smoothie for breakfast. It has to be real food for breakfast, something they have to actually chew with their teeth and swallow, not something that they can drink and that just goes down the hatch for the most part. That's the convenient, easy way, but I want them to take an extra couple of seconds and eat something, because then it sets them up for success the entire rest of the day. Right? So the blue is what they typically do, what that pattern basically establishes over a period of time. The red is what we really want to happen, and that's where the consistency comes in. Now, that's not rocket science. We've all talked about small, frequent meals. I think we've heard that ad nauseum, why that's important, but I think it is. It's kind of the cornerstone of turning this process around. Okay? It may be simple, but it doesn't need to be rocket science in order for it to be effective. The key is getting people to actually do it. Okay? That is the that's where the the rubber meets the road for the most part. That's the hard part, is actually getting people to institute this behavior change. That's really what it is. It's not even so much in nutrition at that point as it is psychology and changing how they how their habits are on a day-to-day basis. It takes 21 days to establish a new habit. So if you can get someone to do it for a month, usually that becomes a new habit. And if they do it for an entire month, their energy is going to be better. Their weight is going to go down a little bit. They're going to have much more energy in the later part of the day. They're not going to have that 2 to 5 o'clock lag like they all have, which is another sign, at least in my book, of insulin resistance. Ask them a simple question. Do you get tired between 2 to 5 o'clock? And I guarantee you 8 out of 10 people will say they do. Okay, if they do, that means you know where they're on the blood sugar insulin roller coaster, and you know what the underlying situation is there and how to correct it. Okay. Now, some supplementation things, and I'll leave it at this just because we're running over a little bit. These are tools. First and foremost, food is number one, but the supplementation can be a very good adjunct and in a lot of cases necessary to change the metabolic dysfunction or maybe speed up the change to the metabolic dysfunction. So omega-3 fatty acids, of course, I think we all know that when it comes to insulin resistance. Chromium, alpha-lipoic acid, biotin, quercetin, basically a form of bioflavonoids. Berberine, there's a lot of good research coming out now that berberine is a constituent in herbs like golden seal, Oregon grape. There's a few other ones that berberine does very well at improving the inflammation that happens in the liver. When I showed you the metabolism of fructose and that big inflammation that was in the middle of the circle, that is part of the inflammation that berberine is having an impact on. Turmeric, also from an anti-inflammatory, liver-enhancing standpoint, and milk thistle as well. There's a lot of other things we could have talked about. I just made a nice quick list for people to jot down. So if you're dealing with insulin resistance, weight loss, obesity, high cholesterol, high blood pressure, fatty liver, these are the kinds of things you should be including in your nutritional plans and getting them on the right path. One last thing about exercise in relationship to insulin resistance. I think that it can be a very necessary component, but the type of exercise is critical to the overall results that are received from that. What is the goal of the exercise? What are you trying to do? Is it weight loss? Is it to improve insulin sensitivity? The type of exercise matters the most, not necessarily how much or how frequent, but the type. And I think the how much and how frequent does play a role. But the type of exercise, I always push people more towards resistance-based training exercise. They don't have to go in there into the gym and throw a bunch of weights around, but they need to move, they need to lift some type or have some type of resistance training to a certain extent. Whether it's their own body weight, whether it's a resistance band, whether it's a machine, whether it's a free weight, whether it's walking uphill with a weighted backpack on their back. There's a lot of different ways to do that. But as opposed to people going out there and running 25 miles on a regular basis. Okay? We want to get people away from the aggressive aerobic exercise and get them more towards exercise that's going to, because the aggressive aerobic exercise is actually making the problem worse. Now, we don't have time to talk about that. We can talk about that later, but when you run a marathon and you go jogging for 5 or 10 or 15 miles, whatever it is, you're raising cortisol, and we just talked about cortisol is very important to maintaining blood sugar and insulin, and that just puts another stress on this whole system that can actually exacerbate these metabolic problems. And I've seen probably several dozen endurance athletes over the last probably year and a half that run probably anywhere from 20 to 50 miles a week that are basically pre-diabetic, okay? Which you would never think that just because they are running all the time and they're quote unquote so healthy and fit, but their blood numbers and their lab tests basically say that they are not, okay? That they are dealing with a significant level of metabolic dysfunction, partially due to how much they train and the kind of diet they consume. Endurance athletes overdo the carbohydrates on a consistent basis because their body's craving it, because they're running so many miles, their body needs the calories, and partially that's where the science is when it comes to endurance athletes, to what they say they should consume. Okay, so if you have a person that's insulin resistant, has to lose a lot of weight, and they want to go out there, go jogging or something like that, or do hours on the treadmill or the elliptical machine, steer them away to a little bit more conducive exercise to what their actual goals are, what you want them to accomplish, because the aerobic stuff isn't necessarily the best. The last one down there says high intensity, short duration. So whatever you do, pick up the intensity and do it for a very short amount of time. A workout for the non-professional athlete should be no more than 30 minutes. If it's 30 minutes, if it's longer than 30 minutes and you're not working out hard enough for the most part, therefore it's not going to improve insulin sensitivity and you're not going to burn any fat. Here's my email if you want to send me any questions. I get a lot of emails, so allow me a couple of days to get back to you. But at least you have it there if you have any questions about it. Turn it back over to you, Paul.
All right, Robert. When you said that you could talk about insulin resistance for the next 2 weeks, you weren't kidding.
Yeah.
Because you just scratched the surface here, and there's I'm very happy that you'll be doing a follow-up on this and can go into more detail and advance it a bit, because it's a very important topic and it's a growing issue, literally, no pun intended, in our culture and around the world as people are eating more and more Western diet. So thank you for this presentation. There's a few questions, if you don't mind taking them.
Sure.
One of it is about fish oil, and if you would recommend average range dose.
So if you look at the literature, and I would encourage you, if this is coming from a student, I would encourage you to go to PubMed and look it up, look at a couple of references, whatever else, but you'll usually see in the literature anywhere between 2 to 3 grams or 2 to 3,000 milligrams as kind of your target dose for omega-3 fat, total omega-3 fatty acids. And I would say that's pretty, a pretty good place to start. I would say, between 2 to 4,000 milligrams is not a bad place. And for more inflammatory conditions, let's say autoimmune disease or something like that, you may be, 4 to 6,000 milligrams. But for something like this, I think 2 to 4 is good. All
right. And this comes from one of your students who was just reading a really great book by Dr. Bruce Feiss called Stop Alzheimer's Now. Has a large focus on coconut oil as being preventative and curative for all sorts of neurodegenerative disorders. But he also talks about how coconut oil is very helpful in dealing with insulin resistance and insulin sensitivity. So this was a comment, not really a question, but if any, do you have any comeback for that about coconut oil, Robert?
Yeah, I think coconut oil is fine. Again, I don't think coconut oil is a panacea by any means, but it is one of those, shunned saturated fats that our body does utilize in very good ways. Not only that, but it does have some antiviral properties and whatever else because of those saturated fats that are in there. So yeah, I definitely think that it has some benefit, but really when it comes to insulin resistance, protecting the brain, whatever else, it is eliminating or minimizing the consumption of the things that are so prevalent in our society, as opposed to there being this one particular thing that is going to cure everything. It doesn't really quite work that way. In our society, it's more about what people are consuming as opposed to what they're not.
Yeah. Yes. Another comment here is about a published article that's on PubMed now, saying that fructose is converted to glucose and glycogen and lactate and fat, and that there's controversy that fructose is the cause of not any more adverse effects than that of excess sucrose. So when you're coming from just a research point of view and not a clinical point of view, there is an article on PubMed that can be accessed by LTAPI that was written in 2010. But it's interesting, the controversy that back and forth on this, Robert.
Well, it's not surprising, and you can't, when it comes to research, you cannot, and this is an example for everyone, because the media is very good at doing this, and I want all of you students never to do this, is to never look at one article and make any conclusions from that one article. Because research, even though it's on PubMed and it's in a respected journal, is probably some of the most corrupt literature on the planet. Okay, so we cannot look at one study and say that it does this or that. Okay, yeah, there's always a controversy, and it's good that there's a controversy. Now we get, if you look at all the research, now you can make your own opinion whether or not this is a valid point or not. Okay, when something is all one-sided, let's say, for example, statin drugs. Statin drugs are a perfect example of all the research, or at least 90% of the research, say how great they are, and very little of the research say that they're not so good. Right? That is when it's skewed and not necessarily ideal, and probably something we should stay away from. Same thing with dairy. There's been a lot of studies over the years that saying how great dairy is. And I think here at the Hawthorn community we probably disagree with that for the most part, at least certain kinds or certain practices that are used. I think the same thing goes with the fructose. We don't know who published it. If anyone has that study, I would love if you emailed it to me. I'd love to take a look at it and read it and see if there's any holes in it and see if there's any ways to pick it apart. But on face value, to say that it's not really as big of an impact as we say it is, that really throws up some red flags, because there's a lot of other research out there that says the exact opposite of that. Right? So it's not surprising that there's kind of a little battle going on, but at the same time, it does raise some red flags.
I do have the whole link for this, and so I will get this to you later tomorrow. Perfect. And yeah. It's too difficult to try to relay over the air. It's too long.
Yeah, I'm sure.
So we'll get it up and we'll have it posted with the rest of the information. But a couple of questions, and certified diabetes educator saying, would incorporating lean protein with meals and snacks lessen the impact of consuming foods with that have a higher glycemic load?
Yeah, this is a very, I hear this all the time, that by having either a fat or protein with a carbohydrate, that you are minimizing the insulin response, and it couldn't be further from the truth. It is the exact opposite of that. That you combine those things together thinking that it's having this blunting effect, but as I stated earlier, it is actually having an exacerbating effect, depending on what the fat is, depending on what the protein is, depending on what the carbohydrate is. That's what we want to get away from, is consuming the fat and the carbohydrates together.
This person also says that being a diabetes educator and see physicians routinely referring people with prediabetes and PCOS for nutritional interventions, and unfortunately they never see blood insulin levels being checked. And this person asked their endocrinologist why, and was told that you can tell if people are insulin resistant just by looking at them. But your stats regarding people of healthy weight with metabolic disorders certainly disputes this. So I thank you for clarifying that and putting that out. And the question that follows is, what about magnesium's role in enhancing insulin action?
Well, magnesium, as any mineral, is going to be a cofactor to a certain enzyme, and magnesium plays a role in probably dozens of different enzymes. And this is what we're talking about. Insulin resistance is a hormonal enzymatic problem for the most part. Now, we're not necessarily talking, or even obesity for that matter, is a hormonal enzymatic problem. Right? So the more cofactors you have, again, vitamins, the B vitamins particularly, and magnesium, selenium, zinc, some of those other ones, those all drive those enzymes in the proper fashion, which then will either steer something towards beta oxidation, which is fat burning, or glycolysis, or gluconeogenesis, or whatever. So yeah, I definitely think I wouldn't necessarily single out magnesium, but I certainly think that it is part of the overall picture of restoring a proper metabolic function.
And just the last couple of things here. Do you have any recommendation of a book on insulin resistance, in particular, that would indicate a particular diet that people can follow?
Let's see. There's a couple of books on the public shelf. Dr. Mark Hyman is one that comes to mind right off the top of my head. He's written quite a bit on this topic. He's coined the term the diabesity epidemic, which is obviously the combination of obesity and diabetes. One of his first books, it wasn't his first one, but one of his original ones was Ultra Metabolism, which was written several years ago now. I still think is a very good book. His new one, The Blood Sugar Solution, there's a few other ones like that. Those are all good. Other than that, I can't really think of one. There's a lot. I think The Perfect Health Diet, I think that's another one by Paul Giamette. That one's a pretty good one as well, too.
Okay. Just a couple comments here. I'm also very appreciative of you talking about scope of practice and not diagnosing, but that it is within our scope of practice to observe. And so thank you for that. And also just something about cholesterol and LDL and HDL, and LDL often being referred to as the bad cholesterol and HDL as the good. But from my point of view, they're both necessary. Our body produces them for a reason. They do different things. They both have metabolic functions, but I think the ratio is really key. And when you're looking at a blood test and people are living a certain lifestyle and eating a certain dietary pattern, and you see these ratios being so out of balance with LDL being very high, then certainly we see complications, and hence it's dubbed the bad type of cholesterol, but in reality it's a normal form of cholesterol that our body produces that should help us when it's operating.
Right.
correctly.
Well, and actually LDL isn't even really cholesterol. LDL and HDL are not even really cholesterols, but we just, for simplification purposes, we call them cholesterol. They're made from cholesterol. They have a component of cholesterol, but they're not actually cholesterol. They're, really kind of transport mechanisms that deliver cholesterol to target cells. LDL brings it to somewhere, and HDL brings it back. And when someone becomes insulin resistant, now, because of that metabolic dysfunction, now you see very particular changes to the size, the shape, the density, whatever we'll talk about later this summer at the next webinar that I do about what those changes, why those changes are occurring. To be honest, I think cholesterol should not really be an indicator or marker of heart disease. I think that it's an old way of looking at the situation. I think they're a much better marker of diabetes and just metabolic dysfunction in general. If your cholesterol is elevated, you're going to have a heart attack? No, probably not. You're going to have a lot of other problems before you have a heart attack. And that's the part that I think is being missed. You take a statin drug, or you take something to lower your cholesterol, problem solved. That's not really true. People, I think, need to be, the general public anyways, needs to be kind of re-educated about what role cholesterol really plays.
And lastly, Robert, you spoke about eggs, and I think the quality of eggs and of all of our foods that we're eating is important. So when you're getting free range versus a commercial egg, you're getting a very different product. But if someone's has difficulty eating eggs, especially if they're allergic to them, do you have another suggestion of protein sources that you would suggest for breakfast?
That one is always the most convenient and easy, and we're just kind of conditioned that way. But to be honest, again, you made a good point there. It's all about the quality of the protein. Now, I do, with my clients and even my students, wherever else, I'm always talking about a protein-driven diet for the most part, but as long as that protein is a higher quality protein. One of the best eggs I've ever had, or a dozen of eggs I've ever had, was from a farm in northern Minnesota. The egg was so strong, you drop it on the floor from mid-waist level and it didn't break. Because the shell was so strong and had so much mineral content. You open up the egg and the yolk is just gleaming orange yellow. You can tell that there's a lot of nutritional value in there. So it's unfortunate that someone would be allergic. And maybe you're right, Paula, maybe some of that allergenicity is related to the lower quality eggs. I'm not really sure.
Yeah, chickens are fed GMO corn, so
yeah, right.
Commercial chickens, and so we want to stay away from soy as being a common allergen. And yeah, your beautiful eggs like that, they weren't GMO-free eggs. So.
No, absolutely not. So yeah, a protein source for breakfast. I don't really have that much preference. I usually have a hard time people getting any protein for breakfast, whether it's a chicken breast, whether it's maybe some salmon, even smoked salmon. That always seems like to be a nice breakfast protein for the most part. I mean, I don't care if people even have leftover steak from the night before, for that matter, as long as it's grass-fed from the butcher down the street, as opposed to the conventional grocery store.
Well, I want to thank everybody for staying late. This was a good discussion and a really excellent topic. I just have a couple of closing topics. I want to let you know that this webinar, as well as many others, will be available on our website. You can find it under Archived Webinars. So you'll be able to access all of Dr. Maki's slides and listen to this webinar again should you want to. Encourage other people that you feel like it would be important and helpful for them to review it. There's a lot of great information on it to really change people's lives. So you can review this and a wide variety of other topics from our previous webinars by going to our archived webinars, and it'll give you a sense of type of subject matter that our students study here at Hawthorn. And I want to thank everybody for attending this webinar. Of course, if you want more information about our programs or courses, please visit our website for more details. And Kathy McDermott, our Director of Admissions, is available for questions. I want to invite you and let you know that our next webinar will be Tuesday, April 2nd. It's at 4 p.m. Pacific time. Our webinars are from 4 to 5 on the 1st and 3rd of the month, and so our next webinar is with our Hawthorn graduate, Nishanga Bliss, and she's going to be presenting on the topic of seasonal eating for spring, and she's already done 2 previous ones for the different seasons, and so this will be a continuation of that discussion, and we'll be sure to let you know more details about that webinar in the coming weeks. I want to thank Dr. Maki for this presentation and your time tonight, and thanks James Bernardinelli for engineering. This concludes our webinar, and I want to thank you all for sharing in this educational experience with us and wish you all the best of health.